All right, it is top of the hour. Let's go ahead and get started. Um, we are presenting today on clinical pearls as it relates to ADHD in the primary care setting. So let me introduce you to our presenter today. Dr. Taya Johnson is a child and adolescent psychiatrist and an assistant professor of medicine here at UTL Science Center at Tyler. Originally from Louisville, Kentucky, Dr. Johnson is board certified in adult, child, and adolescent, as well as forensic psychiatry. So she's a triple threat. She joined a team in fall of 2020 and is one of our 3 CPAN child psychiatrists. Dr. Johnson enjoys educating PCPs about treating mental illnesses in children and adolescents, and you'll see her passion for education here today. Her specialty interests include treating in children and adolescents and young adults with various psychiatric illnesses, especially within the minority populations, and conducting evaluations specifically related to forensic psychiatry. Please join me in welcoming Dr. Taya Johnson today. Dr. Johnson, I'm going to turn it over to you.
Thank you, Laura. Share.
Give us just a second. It does take a moment for us to get those slides up.
All right.
All
Is
right,
it
Dr.
sharing?
Johnson. Yep, it looks good.
And it's just the slide,
It's just,
right?
yes, ma'am.
Okay, perfect. All right. So, as Laura said, this is our clinical pearls for primary care, one of our series presentations on treating ADHD in children and adolescents. Well, I've actually given this talk once before earlier in the year, but because of, newly graduating physicians from residency programs, fellowship programs, and because of new residents coming and starting July 1st, we felt that it would be a good idea to revamp and redo this topic, because this is a topic that a lot of primary care physicians have questions about. And so we're just going to go with this topic. So for today's presentation, our goals and objective are that at the end of this presentation, you should have increased information to identify the signs and symptoms required to appropriately diagnose ADHD in children and adolescents, provide examples of how to screen and assess for ADHD in children and adolescents, and then describe the different treatment options to consider when treating children and adolescents with ADHD. So the prevalence of ADHD. So as of 2016, 8.4% of children in the US aged 2 to 17 years old were diagnosed with ADHD. Of those children diagnosed with ADHD, 62% were taking medication and 46.7% received behavioral treatment in the previous year. About 1/4 of the children diagnosed with ADHD did not receive any treatment in 2016. So with those numbers, we want to talk about, what does ADHD look like? What is it that we're looking for when we're trying to treat ADHD? Because I suspect that some of those children, did not receive treatment for various different reasons, and some of that may be just because it wasn't a clear reason why they were diagnosed with ADHD, or for whatever the reason is. So clinical presentation. So ADHD is a persistent pattern of inattention and or hyperactivity, impulsivity that interferes with functioning and development, as evidenced by inattention and or impulsivity. So when we're talking about the inattention system, so because we're going to break this down into inattention and then hyperactivity, impulsivity symptoms. So when we're talking about the inattention symptoms, in order to get diagnosed with ADHD, you need 6 or more of the following symptoms for at least 6 months. If you are age 17 and older, you only need 5 symptoms. The symptoms need to be inconsistent with the developmental level, and they need to negatively impact social, academic, and occupational activities. And so those symptoms include failure to give close attention to details or making careless mistakes, having difficulty sustaining attention, does not seem to listen when spoken to directly, even in the absence of obvious distractions, does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace, such as, you see them start tasks, but they lose focus and easily sidetrack and may never even get back to finish the task. They have difficulty organizing tasks and activities. They avoid, dislike, or are reluctant to engage in tasks that require sustained mental effort. They lose things necessary for tasks and activities. They are easily distracted by extraneous stimuli, and that may include unrelated thoughts within their mind. And then they are forgetful in daily activities. So again, you need to have 6 or more of these for at least 6 months if you are 17 and younger, and 17 and older, you only need 5 of those symptoms. Now, when it comes to hyperactivity and impulsivity, again, you need 6 or more of the following symptoms for at least 6 months. But again, the age 17 and older, you only need 5 symptoms. The hyperactivity and impulsivity symptoms, again, need to be inconsistent with the developmental level, and they need to negatively impact social, academic, occupational activities. So the symptoms of hyperactivity and impulsivity include often fidgeting with or tapping their hands or feet or squirming in their seat, often leaving the seat in situations when remaining seated is expected, running about or climbing in situations where it is inappropriate. In adolescents or adults, they just may voice feeling a restlessness in their body, but they may not actually be running around and trying to climb walls like little kids would do. They are unable to play or engage in leisure activities quietly. They are often described as on the go or acting as if driven by a motor. They talk excessively, often blurting out answers before a question has been completed, having difficulty waiting their turn, and interrupting or intruding on others. Now, there are other considerations that we need to take into that we need to think about when we are trying to diagnose ADHD, because these symptoms cannot be solely a manifestation of oppositional behavior, defiance, hostility, or failure to understand the task or instructions. So if it seems that a child is not focusing or paying attention or not getting things done because of oppositional behavior, defiance, hostility, or failure to understand only, then you might not be diagnosing ADHD. These symptoms, several inattentive and or hyperactive impulsive symptoms are usually present prior to 12 years old. And so even if we're talking about diagnosing an adult, we can still think back and probably find that they had symptoms when they were younger. They just weren't diagnosed. There is also clear evidence of interfering with functioning, and they is not explained by another mental health disorder. So with my clinical pearls, this is my first clinical pearl slide. What do we think about with when we're diagnosing ADHD? So let's say that we have a patient who comes to us and they only have these symptoms in one setting. So they only have trouble with focusing and paying attention when they're at home, or only have trouble focusing and paying attention when they're at school. We probably should consider another cause of that patient's symptoms, which are usually related to the psychosocial or environmental factors, such as a parenting style, if these symptoms are only present at home, versus the teacher's management skills, classroom management skills, if they're only happening at school. When we diagnose ADHD, we also need to specify the presentation. So we can have combined type, which means that the child or the patient met criteria for the inattention symptoms, which again is 6 or more, 5 or more if older than 17, for at least 6 months. And they also meet criteria for the inattentive the hyperactive impulsive symptoms. Again, 6 or more for 6 months, and then if over 17, 5 or more symptoms. So that would qualify as someone having combined type ADHD. Then you can specify predominantly inattentive ADHD, which the patient meets criteria for inattention, but not for hyperactivity and impulsivity. And that can be the case, like say they have only 2 hyperactive impulsive symptoms. Well, then that means they're predominantly inattentive type. And then you can have predominantly hyperactive impulsive type, which again meets criteria for hyperactive and impulsive, but not for inattentive. So you can have where, they may have 1 or 2 inattentive symptoms, but they have the 6 or more of the hyperactive impulsive symptoms. And then to confirm the presence of symptoms in multiple settings, when you're trying to diagnose ADHD, consult with informants who have seen the patient in those other settings. So it's very, very important to ask parents about home, teachers about school, if they play a sport or, involved with some other kind of extracurricular activities, maybe asking a coach or whoever they interact with in other activities to get an idea overall what their symptoms look like in multiple settings. And then there are several associated features of ADHD, which may include low frustration tolerance, irritability, or mood lability. And so when these symptoms are present, they could be due to ADHD by itself, or they can be due to a co-occurring mental condition such as depression, anxiety, PTSD, etc. So when we have the low frustration tolerance, irritability, and mood lability in a kid who we diagnose or suspect that they have ADHD, sometimes ADHD can be the cause of those mood symptoms, and not that there's another co-occurring condition, because sometimes providers will diagnose depression and ADHD in the same kiddo, and it actually could be that the mood symptoms that they're having is just solely because of ADHD, but it can also be co-occurring with depression, anxiety as well. So we don't want to just completely not diagnose co-occurring conditions, but we also don't want to forget that ADHD has a mood component to it as well. And usually when you treat the ADHD, those mood symptoms improve. So with a differential diagnosis. So one of the clinical pearls is when we have a chief complaint of poor attention and concentration, we have to evaluate for other psychiatric conditions, because ADHD is not the only psychiatric condition which affects attention and concentration. We have to rule out major depressive disorder, because one symptom of depression is poor attention and concentration. Sometimes it is difficult to distinguish between ADHD and depression due to both having symptoms of irritability, which is common in children and adolescents in both diagnoses. But we do have to make sure, we're not missing the diagnosis of depression or rule out a depression diagnosis. We also have to rule out anxiety disorders, because anxiety disorders can present with symptoms of poor attention and concentration due to anxious thoughts. So when we're thinking about generalized anxiety disorder, the patient worries about many different things, which can affect their ability to concentrate on one task. When we think about obsessive compulsive disorder, a patient's obsessions can interfere with their ability to concentrate, especially if they are not able to perform the compulsions to decrease those obsessions. We also have to rule out trauma and post-traumatic stress disorder, because intrusive memories and thoughts can impair a patient's ability to concentrate. And with PTSD, you can also present with irritability and other mood symptoms that look very similar to ADHD. We also have to rule out psychotic disorders, because symptoms of poor focus and attention can be prominent when patients are experiencing hallucinations or disorganized thinking associated with psychotic disorders. And then we also have to rule out learning disorders as well, because children with undiagnosed learning disorders may have symptoms of poor attention and concentration due to just not understanding the school subject that they're being taught. And they also may be oppositional or disruptive to the class. to hide that they are not comprehending they're not comprehending what they are being taught in the classroom. This is one of my favorite slides. I like pulling up this picture because it talks about how anxiety can present in different ways. And then I want to focus in the middle of the slide to the green circle where it talks about struggling to pay attention and focus. That is a symptom of anxiety. And I have seen, providers misdiagnose anxiety as ADHD, and then once we try treatment for ADHD, we actually worsen the anxiety and all the symptoms end up getting worse. So we have to think about that as something that is going on, and not only focus on when someone comes in, I have a problem with focus and attention, or my child has a problem with focus and attention, automatically going to ADHD, because there could be other things causing that, the issues with focus and attention. So now we're going to switch gears and talk about screening and assessment. So when we screen for ADHD, we should do so during the first mental health visit. So if someone comes to you for whatever mental health situation, whether it's they have a complaint of depression, they have a complaint of anxiety, they have a complaint of inattention and focus, make sure to screen for ADHD no matter what the mental health question is, because we don't want to miss it. And so we need to ask questions when they come for that first mental health visit to you. Ask questions regarding inattention, hyperactivity, and impulsivity, regardless of the chief complaint. And then also ask if the symptoms cause impairment. Now, we can also give validated screening tools to help with to help ascertain if symptoms are within a clinical range. And so some of the screening tools that can be used, and this is not exhaustive, but we can use the Conners rating scale, the Vanderbilt assessment scale, and the ADHD rating scale version 4. These tools have both parent forms and teacher forms so that you can assess for symptoms in multiple settings. Now, with a clinical pearl about the screening tools, these tools are only for screening and they are not diagnostic. So if you get a positive screen, then you need to follow with a full, thorough evaluation after that. And to do that, to conduct the evaluation of ADHD, you need to make sure that you perform a detailed interview with the patient and parent. Ask the parent about each of the 18 symptoms associated with ADHD. Obtain information about the patient's school day and or daycare functioning. Also, you make sure to evaluate for comorbid psychiatric conditions. Review the medical, social, and family histories, because ADHD is highly genetic, and so you will likely find a history of ADHD in parents and or siblings. Also, do a thorough developmental history. Many developmental disorders are also associated with attention issues and hyperactivity. So make sure that you do a developmental history to rule out any developmental disorder. And then you may consider getting psychological or neurological testing. This is not required for the diagnosis of ADHD. ADHD is a clinical diagnosis, but if there is a history that suggests low cognitive ability or intellectual disability or low achievement in math and reading related to the patient's intellectual ability, where you're concerned about a learning disability or learning disorder, you might want to get the psychological or neurological testing to help rule that, to help you figure out, is this an intellectual disability, is this a learning disability that's going on, and not necessarily ADHD. And then now we'll switch gears and talk about treatment. So with ADHD, part of your treatment plan should include psychoeducation about ADHD and the different treatment options. There are medication and non-pharmacological treatment options, and we want to include all of those in the treatment plan. Research has shown that pharmacological intervention is more effective than behavioral treatment alone. However, behavioral treatment can be the initial treatment and the only treatment in the following circumstances. If a patient has mild ADHD symptoms with minimal impairment, if you are uncertain about ADHD diagnosis and you kind of just want to do some watchful waiting and see if behavioral interventions will make a difference. If parents reject medication, which that happens a lot, parents are very apprehensive, especially when it comes to stimulant medications for ADHD. And so sometimes you just, they don't want the medicine. So, you try to meet them halfway by having them at least do some behavioral treatment options. Or if there is a marked disagreement about the diagnosis between parents, mom and dad, or between the parents and teacher. Because sometimes, the teacher's rating scale will be, completely different from the parents' rating scale. I've seen it both ways. I've seen it where the teacher's rating scale, the kid it looks like they meet all the criteria for ADHD, where the parents is like, no, hardly anything on their rating scale, or vice versa. And so if there's a big marked disagreement between parents and teachers, sometimes you try just doing the behavioral treatment options. You should also try to provide community support for these patients, specifically for the parents, to help with parent management training so that they can better manage the patient's symptoms, in addition to medications, if they agree to medications. And then it should include school resources such as an IEP, 504 plan, additional time on tests and assignments, things of that nature. Now, a clinical pearl that we make sure to tell families is that neurofeedback, a lot of families have been hearing about neurofeedback and they ask about it. Neurofeedback is not been found to be helpful for ADHD, and there is no specific food modality that has shown to improve ADHD symptoms. So, omega-3s or not eating sugar or any of that, none of those things have shown to improve ADHD symptoms. So when parents ask about that as treatment options, I tell them that information. Now, let's talk about the pharmacological treatment of ADHD when the risk of treatment outweighs the risk of non-treatment. We want to consider pharmacological treatment of ADHD when the symptoms are present in multiple settings, the impairment is moderate to severe, behavioral interventions are inadequate, and or the risk of treatment outweighs the risk of non-treatment. So the first class of medication we're going to talk about for ADHD treatment is the stimulant medications. And the stimulants are highly efficacious in treating ADHD, and they provide the most robust response. So when we are thinking about ADHD treatment, stimulants are going to be our first line. And especially if there is no comorbidity and no reason why you cannot start a stimulant in a patient. And there are two classes of stimulants. So you have the methylphenidate class, and the examples of methylphenidate class include Ritalin, Concerta, Focalin. That's just some examples of the trade names for that class. And then we have the amphetamine class of stimulants, which include Adderall and Vyvanse. Now, both classes of the stimulants, methylphenidate and amphetamine class, they both have the following common side effects. So appetite loss and growth delay, which is a major side effect that most people complain about, and it is typically dose dependent. There could be headaches, stomach aches, nausea, mood lability and irritability, rebound hyperactivity, so increasing hyperactivity, and sleep difficulties. There can be some sleep problems and sleep complaints in those taking stimulant medications. So this is my list of clinical pearls for using stimulant medications. So both stimulant types are equally efficacious for treating ADHD. 70% of patients should respond to the first class of stimulant attempted, and 90% of patients will respond to either class. So usually the class that you pick to start with, usually you will find that the patient responds appropriately to that medication 70% of the time. And then 90% of the time, they're going to respond to either class. So it's really only 10% of the time that you may have someone who fails or does not respond to either class of the stimulants. But that's going to be a very few minority of patients. The odds of responding to the same class if there was no response is very, very low. So if you don't see a response in, like, say you start with the methylphenidate and you don't see a response after going to maximum dose of the methylphenidate, then you should probably go ahead and switch to the other class. It's highly unlikely that you are going to see a response to a different class within, to a different medicine within that same class if they did not respond at all to the first trial within that class. At the present moment, there is no method to predict which stimulant will produce the best response in a given patient. Pharmacogenetic testing is not helpful for stimulant medications whatsoever because stimulant medications have typically little to no metabolism in the liver, which is what the pharmacogenetic test for is liver metabolism. The amphetamines have a little bit of liver metabolism, and then the methylphenidate drugs are not metabolized in the liver at all. So therefore, pharmacogenetic testing, GeneSight, any of those, not going to be helpful for stimulant medication. So just don't even order it and waste the time and energy that it goes into getting those tests. Per milligram, amphetamine stimulants are twice as powerful as methylphenidate stimulants. So because of this, I typically start in younger children, so less than 10 years old. I will start with a methylphenidate class to help reduce the chance of severe appetite loss. A lot of times if you give, a Vyvanse or an Adderall to a kid less than 10, they usually complain of a lot of side effects, specifically with that appetite loss. So that's why usually if you're less than 10, if a kiddo's less than 10, I go ahead and start with methylphenidate. I don't even try the amphetamine first unless they fail the methylphenidate. In general, you should start with an extended release stimulant because it has easier dosing once per day. But at times the patient may require an afternoon booster dose. But you don't have to start with the immediate release and then switch to the extended release unless you have some concerns about the child having some kind of significant side effects or something or the family is apprehensive, so you start with immediate release to make sure that they tolerate it okay, and then you switch to extended release. But that is not required. You can start with extended release stimulant medications. Immediate release stimulants require twice a day or 3 times a day dosing to control ADHD symptoms. So they may not be beneficial in some cases. However, in those that may be sensitive to medications, you might want to consider starting with the immediate release to determine the dose that works for them, and then change to extended release once you find that dose. Again, it's not required, but if you have concerns or parents have concerns about starting straight out with extended release, you can start with the immediate release. I will say though, in small children, so when I'm saying small children, I'm talking mostly like my 3 to 4, 5-year-olds. I usually start with immediate release stimulants in those kids because usually there is no extended release forms that sufficiently allow for lower dosing. So say, I only want to try 1 or 2 milligrams of methylphenidate in a small kid, a 3, 4, 5-year-old kid. It is easier to do that with the immediate release version of any of the stimulants versus trying to do that with extended release, because usually the extended release medications, you can't crush them or chew them or anything like that, so it's hard to make those smaller dosing increments. And then when you start a dose, you can titrate up the dose every 1 to 3 weeks until the maximum dose is reached, or symptoms of ADHD remit, or the side effects start showing up and it prevents you from titrating further. So you can start at 1 dose at week 1, the next dose at week 2, just keep going up in increments until one of those 3 things are reached. Either the maximum dose is reached, the symptoms of ADHD remit at a dosing level, or the patient develops side effects and you can't go up to any higher dose. Now we'll talk about the non-stimulant medications. So there are several non-stimulant choices for ADHD. The first class we'll talk about are the alpha agonists, which include guanfacine, which comes in 2 versions, extended release and immediate release. Extended release is also known as Intunev. The immediate release is known as 10X. And then clonidine, which also has extended release known as Capvay, and then immediate release, which is just clonidine. Now, regarding using non-stimulants, the alpha agonist specifically. They are not as good for ADHD alone, but they work very well in combination with stimulants. So it's not uncommon that you might have someone on a stimulant and one of these alpha agonists. They are very effective for impulsivity and hyperactivity, sleep disturbances, specifically insomnia. They help with modulating mood level and aggression, and they can help with tics if tics are developed or become worse with stimulants. Now, it takes about 4 to 6 weeks of taking the alpha agonist for you to see some type of effect. So these are not going to be immediate response like you see with the stimulants. With the stimulants, you'll know within a week if that stimulant is working or not. With the alpha agonist, you got to give it 4 to 6 weeks before you can even know if it's effective. And then with the alpha agonist, you must taper off to avoid rebound hypertension, because that is a known side effect of withdrawing alpha agonists too quickly without doing a taper. So you have to taper off with the alpha agonist. And the side effects of the alpha agonist include sedation, headaches, and sleep disturbances. Now, another non-stimulant is atomoxetine or Strattera, and that is a noradrenergic reuptake inhibitor. With atomoxetine, with Strattera, you start 0.5 milligram per kilogram for 1 week, and then you double the dose. If there is no effect on the full dose after 3 weeks, you change to another medicine. And full dose meaning going all the way to max FDA approved max dose. With Strattera, you should consider using this medication in patients who have comorbid anxiety, if you have a patient with history of substance use disorders, or if you have a patient with severe tics, because in those situations, in anxiety, substance use disorders, and tics, the stimulants may not be such a good option for those patients, but you can use Strattera in those cases. Side effects of Strattera include headache, stomach ache, and then there's the black box warning for suicidality, but that is very, very rare. That is not a main concern with Strattera. And then another non-stimulant is Wellbutrin or bupropion, which is a norepinephrine dopamine reuptake inhibitor. This is third line for ADHD treatment. I usually consider this in a child or adolescent who has comorbid depression along with their ADHD, especially if they are taking a stimulant but they're still having some mood symptoms. I may use them together or by itself, trying to kill two birds with one stone, targeting the ADHD and the depression in the one with using one medication and decreasing polypharmacy. But Wellbutrin is third line. Would also use it in the case of substance use disorders as well, if you have someone that you don't want to put on stimulants. So Wellbutrin is an option. Now, clinical pearls. If a patient with ADHD has a robust response to pharmacological treatment and has normal functioning, then pharmacological treatment alone is sufficient. Now, because usually most cases with most mental illnesses, I'm always going to say that patients need to be involved in therapy along with medications. In the case of ADHD, if they have a robust response to the medicines and they're back to normal, then they can just have medication treatment alone in those patients. If a patient has less than optimal response to medicines and has a comorbid disorder and has stressors in their family life, psychosocial treatment along with the medication is often beneficial. So doing therapy along with the medications in those cases is going to be beneficial. You should continue treatment as long as the symptoms remain present and cause impairment. However, we have found that most patients will stop stimulants on their own at some point during their course of treatment, because at some point they're going to say, I can do this on my own. I don't need the medication anymore. so I'm going to stop it. And they'll stop it. And then usually they end up coming back at some point saying, no, I actually really need that medicine. Can we get back on it? So that will happen. But you try to recommend that they don't do that without at least discussing with you first and making you aware of them making that choice. Of course, we can't always guarantee that our patients will do that, but we try to make sure they do that. This ADHD medication guide is awesome. I absolutely love it. You can get it from the website www.adhdmedicationguide.com. This one was last revised in November 2019. I don't know how often they revise them, but they do revise them and update them with the newer ADHD medications. So this is one side of it, and this is the methylphenidate side. And so you have in this pink box the long-acting versions, extended release versions of the methylphenidate options. In this blue box, there's this the new medicine Jornay methylphenidate that actually has you take it at night. The patient takes it at night, and it has a delayed release and it's extended release. That's in that blue box there. That's a newer one. And then this yellow box is the short acting or the immediate release methylphenidate options. And then on the other side, you have the amphetamine options in the green box, long acting extended release, amphetamine short acting in this orange box, and then in this fuchsia, I guess, colored box at the bottom, you have the non-stimulant options, Intuitive, Capvay, and Strattera. So these are my resources. That very first hyperlink is where you can get that ADHD medication guide. If you would like to have one for your office, I reference it all the time because it's very helpful. It gives you, the different dosing options that you can have with prescribing it, and it tells you the max dose. It tells you the age that you can start the medicine, that's FDA approved to start the medicine. So I really, really like that medication guide. And now we will talk about the Child Psychiatry Access Network. Laura will take over from here.
Thank you, Dr. Johnson. That was wonderful as always. And let me go ahead and pull a slide up here real quick for y'all. All right. Dr. Johnson, are you able to see my slide on CPAN?
Yes, ma'am.
Great, thanks. So thank you all for joining us today. A couple of things I want to share with you. My name is Laura Young. I am the program manager and very fortunate to work here at UT Health Science Center at Tyler with the CPAN program. CPAN, if you are not familiar with it yet, is the Child Psychiatry Access Network. It is a hub facilitated service available for all PCPs in the state of Texas. So we are 12 health-related institutions across the state of Texas that facilitate assistance for PCPs, so physicians, nurse practitioners, and PAs as they're working with children and adolescents. We provide child psychiatry consultation direct to you, real time. We also provide assistance with care coordination. When I talk about care coordination, I'm talking about things such as helping to find resources and referrals, as well as assistance with questions related to testing, questions about providing information for your clinic as far as crisis plans. We can help provide some information about that. And then the third piece that we provide is what you've witnessed today is our Child Psychiatry Access Network, CME options. So if you are not yet enrolled in CPAN and you are a PCP in the state of Texas, you can contact us more at the CPAN info at uthct.edu link. You can also give us a call the numbers listed below. If you choose option 1 and option 3, that'll get you directly to one of our 2 therapists who can provide you more information. And we will talk a little bit more with you about CPAN when you call. If you are if you are located in the Northeast Texas region, and you are able to see that in this little tiny map here, we will be serving you with our program. If you're located somewhere else in the state of Texas, since all 254 counties are served, you will have a regional hub that will be supporting you. So again, if you are not familiar with Child Psychiatry Access Network and would like more information about how we can provide you with real-time child psychiatry consultation, referrals, resources, and continuing education, please give us a call. The next thing I want to share with you really quickly is a bit about our Project Echo that will be beginning here shortly. So Project Echo, if you're not familiar with it, is a cohort-based learning that was developed out of out of the University of New Mexico. ECHO is an international program that provides training and education through experts in the field to those who would like more information and education on certain topic. Project ECHO for Texas CPAN will begin in August. Each hub has their days that they're going to be presenting this. We have 7 sessions within our first series, which are listed on the left, you will see. And this is available for PCPs across the state of Texas. If you're in the Northeast region, we would be providing that for you. It'll be held every other Friday from 12 p.m. to 1 p.m. The facilitation is simple. We will be providing 15 minutes of an overview of a specific topic. So for example, when we have our second series, we'll have a 15-minute PowerPoint presentation on behavior disorders across adolescents. And then we'll be discussing cases related to that topic. So providers will join us. They can submit cases for us to talk about. Certainly, we will not have any PHI included, but it is a time to bring cases forward and to discuss. They can be cases that are currently active that you're working with a patient, or they can be cases that you have had a history with that you would like to learn more about and how to facilitate the care of that child or adolescent going forward. For more information about Project Echo for UT Health Science Center here in Tyler, or to register your interest in that, you can either go ahead and use our QR code here on the bottom right, or you can contact us at our email address, UT Health Science Center, CPAN info at UT Health, one more time, CPAN info at uthct.edu. There's also a link here in forms that you can type in to your browser. So let me pause right now, and we have some time for questions. So I would like to open that up. Are there any questions from attendees today? Dr. Johnson, I will ask a question. So you had talked about ADHD and the manifestations of it, one of which is poor sleep. How early can that poor sleep be evidenced by the family?
When you say how early, you mean age or?
Yes, yep, absolutely age.
It can be noticed, right away. Like the families may notice that they usually say, well, they always had trouble sleeping. Like, they were never really a good sleeper as a baby. When they think back, when they retrospective, they're like, oh, they never really slept well when they were an infant. They always struggled getting them to sleep. They had difficulty settling down, but they may not have thought that was anything related to ADHD or anything like that, until later symptoms come along when they're attending school or something like that. So usually it's one of those retrospective things where they're like, oh, you know what, I did notice that they had issues with sleep when they were a toddler. Or an infant, but they didn't think anything of it, because they're like, oh well, babies have trouble going to sleep
Mhm.
sometimes, or there's sleep is always a thing. So it could be noticed pretty early, but they probably don't equate it to something like ADHD or anything else until they get older and are able to see other symptoms.
All right. So this might be the kiddo that's getting up out of bed 20 times every night and the parent is having to take them back to bed and they crawl back out and they get back in.
Mm-hmm.
That kind of a scenario.
Yes.
Excellent. With that same along those same lines, what other of the symptoms that you had talked about might be seen really early like that?
So usually if I'm diagnosing, I, first of all, I don't typically like to diagnose ADHD in a 3, 4 year old, because, developmentally, we should not be expecting them to sit still all the time, for hours and hours on end. They should be, kind of wiggly worms a little bit. But when it becomes obvious, I can always tell when I have a patient in my office, it is obvious that this is more than a typical 3, 4 year old, when I have a kid that's just moving around my office so much to where, they're almost climbing up the walls, like literally like a Spider-Man type of thing. And, they pull out every single toy that I have in my office, and they're just all over the place, messing with the light switch and messing with this and messing with, just everywhere, all over the place. And you can kind of tell, okay, there are this is not a typical 3, 4 year old. Like, you expect some busybodiness in a 3, 4 year old, but when they're just like, you can tell they can't contain it, they can't pull it in at all, like they are literally all over the place. That's usually what you notice first. You don't really notice the inattentive stuff early. It's usually the hyperactive, impulsive behaviors that you notice first.
So as a parent, what I might be seeing is that the kiddo that can't sit when they go out to dinner, this is the kiddo that can't sit in the high chair, that's constantly trying to crawl out.
Just constantly trying to crawl out. Or like, I had one lady, one patient, a mom, she was like, Dr. Johnson, every time we're in a store, I put him in the shopping cart, I turn to just grab something off of the shelf, and he's almost standing up in the shopping cart, getting ready to fall out and hurt himself. It's like, okay, yeah, this is like, this is dangerous behaviors. He could hurt, really hurt himself if he falls out of the shopping cart. But it's like nothing that she does will keep him contained sitting in the shopping cart while she's trying to, get things off the shelf. So it's those
Mhm.
type of situations.
Absolutely. And I guess the reason I'm getting to this here is that it may be that the parents are mentioning some of these in the early visits, or might have providers on here that are not necessarily physicians, but maybe nurses, and they're seeing some of that behavior even earlier than typically a parent might think of it. That's one of those areas where they can keep that in mind and maybe do some education with that parent of asking other questions that may be noticeable in some of
Right.
those behaviors.
And then the caveat with that too is, because I've had a lot of parents who have unrealistic expectations for what 3 and 4 year olds are supposed to do as well. And so, I have to explain to them, we're not there's no way we are to expect a 3 and 4 year old to sit still for hours and hours a day in front of a TV screen, or in front, like, what, like, no, they are going to move. They are going to move, do other things. So it's not just because you can't get them to sit still for hours on end. That also is not ADHD as well, because that's not developmentally appropriate to try to have that expectation for a 3 or 4 year old. So we also have to, make sure that we let parents know some hyperactivity movement is okay, is developmentally okay. And that's why in the diagnosis of ADHD, it says behaviors that are symptoms that are developmentally inappropriate.
All righty. We do have a question in the chat, and I don't know if you're able to see it or not. If not, I can read it for you.
Yes, I see it. And that question says, are there ADHD formulations you find more efficacious, like Vyvanse versus Adderall extended release or otherwise? No. Literally, you just try one and see if it works for that patient, but they're all equally efficacious across the board. It's just a matter of which one works the best in that specific patient.
Great. So do we have any other questions from our attendees today? If so, feel free to unmute yourself. Dr. Johnson, is there anything else you think might be important for attendees to know that wasn't necessarily in your presentation, but as we've been talking here, maybe something else that for consideration?
One thing that I just want to make sure to focus on again is the mood component of ADHD, because I feel that a lot of providers, psychiatrists included, but a lot of providers forget that ADHD has mood symptoms associated with it. And usually you will notice a difference in those mood symptoms once you get the ADHD under control with medication. So it's, again, not one of those situations where you have to do a stimulant medicine and a medicine specific to the mood. It's like, I typically will, in those cases, I will typically, okay, if the ADHD symptoms are the more concerning issue, which usually they are, I start with the treatment of that first, because we can know if that medicine is working. Like I said, within a week, we know if the medicine is working, not working, and we can adjust the dose from there, versus starting a medicine, a stimulant and an SSRI, and we might not even need to do an antidepressant at all, because those symptoms of the mood, lability, irritability improve once we get the ADHD under control. So just to continue to remember that ADHD has a mood component associated with it is very, very, very important, because I think providers just forget, because they only focus on the hyperactivity and the inattention symptoms of ADHD and forget that the mood component is a large component of it as well.
All right. And last question that I have for you. I think that there's a question in many parents' minds that, is there a component impacting ADHD related to screen time or use of television as a common um, type of pacifier for children? Is that cell phones and all the different electronics, is that increasing? Is there any data back on showing that, or it seems like there's a lot more ADHD?
Um, so I think that's twofold. I think one thing is, it seems like there's more ADHD because I believe that we are looking for it more. I don't necessarily think that it's any more prominent than it had been before. It's just that I feel that we as a field of medicine look for it more now. But the other thing is, I don't know specifically if there's data or research that shows that screen time worsens that or has contributed to us diagnosing it more. But I will say that parents a lot of times will say, well, they don't have ADHD because they're able to sit in front of the TV all day long or play video games all day long, and they can focus on that. And it's like, yeah, they'll be able to focus on what they want to focus on, for the time being. But there's other areas in their life where that focus and concentration is not there, because it's, more difficult or more mentally taxing, and so they don't focus as well compared to, you know, doing a fun video game.
All righty. We did have another question come through. Are there any online resources for parents for behavior modification?
The American Academy of Child and Adolescent Psychiatry website has a lot of online stuff for parents. Like there's a whole page for parents for specific mental health diagnosis and treatment options and things of that nature. Not just ADHD, but there is a whole parent section, parent and family section on the American Academy of Child and Adolescent Psychiatry's website that has a lot of resources for that kind of stuff.
Excellent.
I'll refer
Any
to
other? Go ahead.
And Dr. Kerr added in the chat that Chad is another resource as well. And she put the website in the chat too.
That's great. And for those of you who don't know Dr. Kerr, she is one of our child psychiatrists as well. And then we have a third, Dr. Jamin Blood. All right. Any additional questions? All right. We thank you for joining us today for Clinical Pearls in the Primary Care. And we will see you hopefully on the first Wednesday of August. And we will continue to have continuing education offerings the first and third Wednesday of the month from 12 to 1. Watch your emails for that information, as well as the Facebook page for Texas CPAN. If you have any questions, please feel free to email us at cpaninfo@uthct.edu. If you would like continuing education credits, please complete the continuing education form that you can either access through the link you see, or I also put that in our chat, as well as the QR code on your screen. We appreciate your time very much. Have a great day.